today's video, we're going to be talking about what messengers initiate acute inflammation. By the end of this video, you will completely understand why we need inflammatory mediators, toll-like receptors, arachidonic acid metabolites, mast cells and histamine, complement system, and also Hageman factor, also known as factor 12. For additional resources, I recommend you check out the healingpathofnature.com and also our Patreon for exclusive details and also the best materials available on the market. So to start, why do we need inflammatory mediators? So inflammation is not a passive process. It requires communication and coordination among immune cells. This is where inflammatory mediators play a crucial role. They are chemical messengers that help initiate, amplify, and resolve inflammatory processes. Think of inflammatory response as a battlefield. Immune cells are the soldiers, and inflammatory mediators are the signals and orders that tell them where to go, what to attack, and when to retreat. When it comes to acute inflammation, these mediators trigger several different factors. 1. Vasodilation to increase blood flow and bring immune cells to the site of injury. Increased vascular permeability, allowing plasma proteins and immune cells to exit blood vessels and enter tissues. Neutrophil recruitment and activation, bringing in the first line of immune defense, and pain and fever to alert the body and promote immune deficiency. The three major categories of acute inflammatory mediators include pattern recognition receptors, for example, toll-like receptors or TLRs, arachidonic acid metabolites, prostaglandins, and leukotrienes, and mast cells with histamine. What are toll-like receptors, also known as TLRs? This is the alarm system of innate immune system. So toll-like receptors are a type of pattern recognition receptor, PRRs, found on innate immune cells such as macrophages, dendritic cells, and neutrophils. They act as early warning systems, detecting pathogen-associated molecular patterns, also known as PAMPs, that are unique to infectious microbes but absent in host cells. So how do TLRs work? TLRs recognize pathogen-associated molecular patterns, also known as PAMPs, which are molecular signatures that are unique to infectious agents but are absent in host cells. So an example is CD14, a co-receptor for TLR4 on macrophages, recognizes lipopolysaccharide, LPS, a component of the outer membrane of gram-negative bacteria. This activates NFKB, a transcription factor that turns on genes involved in producing inflammatory cytokines like tumor necrosis factor alpha, interleukin-1, and interleukin-6. A high-yield example are mutations in TLR signaling can lead to immunodeficiencies like MyD88 deficiency, which results in recurrent bacterial infections. Also, chronic activation of TLRs contributes to diseases like sepsis, rheumatoid arthritis, and atherosclerosis. TLRs bridge innate and adaptive immunity. They are also found on lymphocytes and play a role in chronic inflammation. Clinical relevance, I recommend you take a picture of this chart I made for you guys or visit our website for more details. So right here we have different disorders like you can see. First, like we talked about, the MyD88 deficiency, the defect in MyD88 receptor results in recurrent pyogenic bacterial infections like streptococcus or staphylococcus in early childhood due to impaired inflammatory response. Also with sepsis, overactivation of TLR4 due to LPS, this leads to systemic inflammatory response and a cytokine storm, hypotension, and multiple organ failure. Additionally, autoimmune diseases like lupus, rheumatoid arthritis, etc. is chronic activation of TLRs. This results in persistent inflammation and tissue damage. Additionally, major TLRs or toll-like receptors and their PAMPs. So TLR2 recognizes peptidoglycan and lipoteroic acid on gram-positive bacteria. TLR3 recognizes double-stranded RNA on viruses like HSV and reovirus. Toll-like receptor 4, as a co-receptor with CD14, recognizes lipopolysaccharide, LPS, on gram-negative bacteria like E. coli, Pseudomonas, Neisseria. TLR5 recognizes the flagellin on motile bacteria like Salmonella and Listeria. TLR7 and 8 recognize single-stranded RNA like RNA viruses including influenza, SARS-CoV-2, and TLR9, which recognizes unmyelinated CpG DNA on bacteria and DNA viruses. Some key takeaways: TLRs recognize PAMPs, which activate NFKB, which contributes to cytokine production and inflammation. Remember, CD14 is also a co-receptor for TLR4, which recognizes lipopolysaccharide recognition and is a key in sepsis pathogenesis. Another one, MyD88 mutations equals a weak immune response, which equals recurrent bacterial infections. Also, overactivation of TLRs contributes to chronic inflammatory and autoimmunity. Toll-like receptors are pattern recognition receptors found on innate immune cells like macrophages and dendritic cells. They function like an early warning system detecting invading pathogens by recognizing unique molecular patterns found on microbes. Next, arachidonic acid metabolites, the fire starters of inflammation. Arachidonic acid is a polyunsaturated fatty acid that is stored in the phospholipid bilayer of cell membranes. When an inflammatory response is triggered, phospholipase A2 releases arachidonic acid, which then can be metabolized into two major enzyme pathways. As you can see, we have the COX enzymes convert arachidonic acid into prostaglandins, which have a variety of inflammatory effects. First, PGE mediates vasodilation, increased vascular permeability, pain, and fever. Remember, E for fever. Prostaglandin I2, I for inhibiting clotting. So vasodilation and inhibition of platelet aggregation prevents clotting. Also, PGD2 promotes vasodilation and attracts eosinophils. Some high-yield concepts as NSAIDs like ibuprofen and aspirin inhibit COX enzymes, reducing prostaglandin production, thereby decreasing pain, fever, and inflammation. COX-1 inhibition leads to gastric ulcer risk. COX-2 inhibition is selective in spare stomach but increases cardiovascular risk. The next pathway is the 5-lipoxygenase pathway. It produces leukotrienes, or LTs, key leukotrienes in their function. LTB4, B for brings in neutrophils, is a powerful neutrophil attractant and activator. LTC4, LTD4, and LTE4, aka slow reacting substances of anaphylaxis, causes vasoconstriction, bronchospasm, and increased vascular permeability. Remember that asthma patients have increased leukotrienes to bronchoconstriction. Some key concepts: prostaglandins, vasodilation and pain, leukotrienes, bronchospasm, and neutrophil recruitment. Next, mast cells, which are the first line of defense against allergens and injuries. There's two distinct pathways. The immediate response involves release of perforated histamine granules, which mediate vasodilation of arterioles and increase vascular permeability. The delayed response involves production of arachidonic acid metabolites. So histamine, the immediate responder in inflammation. How does histamine work? Histamine is like an alarm system. It released immediately when inflammation is triggered and is responsible for the earliest vascular changes. It is stored in perforated granules of mast cells, basophils, and platelets. It is released in response to physical injury like tissue trauma, direct degranulation, anaphylatoxins like C3A and C5A, complement activation triggers degranulation, cross-linking of IgE on mast cells in allergic reactions. They act on H1 receptors to cause biodilation of arterioles, increasing blood flow like redness and warmth, increases vascular permeability of post-capillary venules, leading to fluid leakage into tissues, swelling and edema, and also bronchoconstriction, which is important in asthma and anaphylaxis. Histamine has a dual role. It's immediate versus delayed response. The immediate response, which happens in seconds to minutes, releases perforated histamine granules, causes rapid vasodilation and increased permeability. This allows immune cells to exit the bloodstream and enter tissues. There's also the delayed response hours later, where mast cells also activate the arachidonic acid pathway, leading to leukotriene production. Leukotrienes sustain inflammation by further increasing permeability and recruiting neutrophils. Some clinical relevance. Remember, histamine plays a major role in allergic reactions. For example, anaphylaxis and hay fever. Antihistamines, H1 blockers, prevent histamine effects. In anaphylaxis, epinephrine is required to counteract histamine-induced bronchospasm and vasodilation. So how does epinephrine work in anaphylaxis? Remember, epinephrine reverses histamine's effects by stimulating A1 receptors, also known as vasoconstriction, and B2 receptors for bronchodilation. The complement system, also known as the backup army in inflammation. What is complement? The complement system consists of pro-inflammatory plasma proteins that enhance immune defense. They are inactive in circulation but become activated in response to pathogens or immune signaling. How is the complement system activated? There are three major pathways leading to complement activation. First is the classical pathway, triggered when C1 binds to IgG or IgM that is already attached to an antigen. Remember, GM makes classic cars, IgG and IgM meaning the classical pathway. The alternative pathway, activated directly by microbial products, for example, endotoxins, LPS from gram-negative bacteria, without antibody involvement. There's also the mannose binding lectin pathway, the MBL pathway. MBL binds to mannose on microbial surfaces, triggering complement activation. So a key chart I have made for you, I'd recommend taking a picture of this. To start, you have C3A and C5A, anaphylatoxins that trigger mast cell degranulation, releasing histamine, leading to vasodilation and permeability. C5A is also a chemoattractant for neutrophils. It guides them to infectious sites. C3B binds to pathogens. C3b for binds. C5b plus C6 through C9 is the membrane attack complex, or the MAC. This forms a pore in the microbial membranes, leading to direct lysis, especially effective against gram-negative bacteria. Some clinical relevance. Deficiencies of C5 through C9, the MAC components, increase susceptibility to Neisseria infections. Also, C1 inhibitor deficiency leads to hereditary angioedema. Unregulated bradykinin release causes recurrent swelling episodes. Also, paroxysmal nocturnal hemoglobinuria, PNH, caused by a lack of complement regulatory proteins leading to RBC lysis. What is Hageman factor? Hageman factor, or factor 12, is an inactive pro-inflammatory protein produced by the liver. Unlike histamine and complement, factor 12 is activated when it comes into contact with subendothelial or tissue collagen, for example, during endothelial injury. What does factor 12 activate? First, it activates coagulation and fibrinolysis, contributes to clot formation and breakdown. Next, it also activates the complement cascade, further amplifying inflammation. Also, the kinin system. Remember, the kinin system produces bradykinin, which mediates vasodilation, similar to histamine, increased vascular permeability, fluid leakage into tissue, and pain sensation, similar to prostaglandins. Factor 12 plays a role in disseminated intravascular coagulation, or DIC, particularly in gram-negative sepsis. DIC is a widespread activation of clotting factors, leading to microthrombotic formation and subsequent bleeding. The interplay of mediators in acute inflammation. Remember, each mediator plays a distinct but interconnected role in acute inflammation. Key takeaways for you to remember: histamine and bradykinin equal vasodilation and permeability. Complement is opsonization, chemotaxis, and microbial lysis. Factor 12, or Hageman factor, activates coagulation, complement, and the kinin system. So that concludes our video for today. If you found this helpful, be sure to like and subscribe. Also check out thehealingpowerofnature.com and also our Patreon for exclusive study material and the best materials available on the market. We appreciate your support and look forward to seeing you next time. See ya.